Welcome to the deep dive.
Great to be here.
We're taking your source material today. It's a set of really useful revision notes, and we're going deep.
hmm
Our focus is syncope, or fainting. The plan is simple. Extract the high-yield stuff, the key concepts, maybe some memory triggers. Basically make revision efficient. Think of it as a shortcut to getting your head around this topic.
Absolutely. Dense notes are great, but sometimes you need that conversational breakdown to make things stick, right? Breaking it into memorable chunks is definitely key. Let's dive in.
Okay, let's start right at the beginning. Based on these notes, what's the core definition? What is syncope?
So the notes define it pretty clearly. It's a brief loss of consciousness,
Okay.
but the really crucial part is the why. It's specifically due to reduced blood flow to the brain, like a temporary power cut upstairs.
Got it. Power cut to the brain.
Exactly. And the notes highlight the key features. Sudden onset, it's short, and there's complete spontaneous recovery. Those three, sudden, short, complete recovery, are the real hallmarks.
Sudden, short, complete recovery, low brain blood flow. Seems clear. But the notes mention things that look like syncope but aren't. What's the main one we need to watch out for?
Yeah, that's a super important differential, especially for revision. The notes flag psychogenic pseudosyncope.
Pseudosyncope. Okay.
It mimics syncope, it's involuntary, often seen in younger adults, maybe with anxiety issues according to the notes. But the big giveaway is duration.
Ah, how long it lasts.
Exactly. True syncope is really brief seconds, maybe a minute tops. Pseudosyncope, the notes say, often goes on for minutes with the person lying on the floor.
Minutes.
Ah.
That's quite different. Are there other signs mentioned?
Yes, definitely. The notes point out that in true syncope, you often get pallor, maybe sweating, that clammy look.
Right.
In pseudosyncope, the notes say these are usually absent. And another interesting point from the notes, the eyes are often tightly closed during pseudosyncope. In true syncope, they might be open or briefly open, then closed.
Closed eyes, no pallor, lasts longer.
Okay, useful clinical clues. Is there a test that helps sort this out? There is. The notes mention the tilt table test.
Right.
For vasovagal syncope especially, this test can often trigger that drop in heart rate and blood pressure, basically replicating the event. But for psychogenic pseudosyncope, the notes emphasize the tilt test shows no significant vital sign changes. Getting this differential right is, well, it's vital.
Good point. Okay, definition sorted, main mimic covered. Let's talk about the why. The notes go into pathophysiology, the mechanism, and etiology, the causes. What's happening under the surface?
So the notes link it all back to that fundamental problem, disrupted blood flow to the brain.
The power cut again.
Exactly. And the notes say this disruption can happen in a few main ways. Either the heart's not pumping enough blood out that's reduced cardiac output,
Pump failure.
or the blood vessels relax too much across the body, causing blood pressure to tank vasodilation.
Pipe problems.
Or there's an issue with the autonomic nervous system, the body's automatic control system that usually keeps blood pressure steady.
Control system glitch. Pump, pipes, or control. Makes sense.
Yeah.
And the specific causes listed in the notes, they fit into these.
They do nicely. The notes group them. The biggest group often is neurally mediated syncope, NMS. This is your common faint.
Right.
It includes vasovagal syncope triggered by things like emotion, pain, seeing blood, or orthostatic stress like standing too long. Also, situational triggers like coughing, sneezing, even swallowing or peeing, mentioned in the notes.
No, okay.
NMS also covers orthostatic hypotension, that significant blood pressure drop specifically when you stand up. The notes say this can be due to autonomic failure, some medications, or just being low on volume, like dehydration.
So NMS is kind of the reflex or nerve-related type. What's the other major category, the potentially more serious one?
That would be cardiac syncope. The notes flag this one up, often due to arrhythmias, electrical problems with the heart rhythm.
Like the heart beating too fast or too slow.
Exactly. The notes list examples like sick sinus syndrome, the natural pacemaker isn't working right, or AV conduction disease where the signal gets blocked, or tachycardias, dangerously fast rhythms. Structural heart diseases are also in this group, things like severe valve problems or cardiomyopathy that physically stop the heart pumping effectively.
Okay, so heart rhythm or structure issues. And the notes had another bucket too.
Yeah, a bit of a catch-all. Structural cardiopulmonary things like a massive pulmonary embolism or severe pulmonary hypertension. Cerebrovascular causes, though the notes suggest isolated syncope from this is less common than, say, dizziness. Substance abuse is in there, and the psychogenic factors we talked about earlier.
Right, so it always comes back to that interrupted brain blood flow caused by nerve reflexes, the heart itself, or this kind of mixed bag of other things.
That's a really good summary of the why from these notes.
Okay, so who gets this? Who's most likely to faint? Let's look at risk factors and epidemiology in the notes.
Well, age is a big one, according to the notes. But it's interesting, it peaks in two groups: teenagers and adolescents, and then again in older adults.
Two peaks.
Family history is mentioned, suggesting a genetic link in some types. Having existing cardiovascular disease is a major risk factor, especially for those cardiac causes.
Makes sense.
And then simpler things. Dehydration, standing still for a long time, classic triggers for vasovagal episodes. And medications are a big one highlighted in the notes, especially antihypertensives and diuretics.
Yeah, you can see how messing with blood pressure or fluid balance could cause problems, especially standing up. How common is syncope overall? What do the notes say about UK numbers?
The numbers are quite striking, actually. The notes say annual incidence is somewhere between 1% and 3% in the general population. That's quite common.
1 to 3% a year. Wow.
Yeah. And prevalence really climbs with age. The notes mention around 40% of people over 70 have experienced it.
40%, that's enormous.
It really is a major thing in older populations. The notes specify NMS is common in the younger group, the teens and adolescents. In older adults, it's often cardiac causes, orthostatic hypotension, sometimes postprandial after meals or medication effects. It ties back to the risks.
Right.
The notes quote a lifetime risk of 42%, with that peak prevalence between 10 and 30 years old. For the over 80s, the annual incidence is nearly 2%. But importantly, the notes also say a definite diagnosis is usually possible in most elderly patients.
That's good to know that it's often figure-out-ovable even in that high-risk group. Okay, we know what it is, why it happens, who gets it. Now, the practical side, what do you actually see? What do you ask? Clinical features?
Well, the core is still that sudden temporary loss of consciousness with full recovery. But the notes really emphasize looking for prodromal symptoms, warning signs before the blackout.
Ah, the warning signs. Like what?
High-yield ones from the notes include feeling lightheaded, dizzy, maybe palpitations, nausea, breaking out in a sweat, feeling weak, or vision blurring or tunneling. These often point towards NMS.
So it doesn't always come completely out of the blue. And the notes are really emphatic about history taking, aren't they?
Absolutely critical. The notes basically say getting an accurate history, ideally with an eyewitness account if possible, is the single most valuable diagnostic tool. For revision, this is your checklist. The notes literally list the key questions.
Okay, run through that checklist for us. What are the must-ask questions from the notes?
All right, here we go. First, was the loss of consciousness actually complete? Helps distinguish it from just feeling faint.
Okay.
Second, was it temporary? How quickly did it happen and how quickly did they recover? Duration, again, is key.
Right, duration.
Third, were there any warning signs? That prodrome we just mentioned, lightheadedness, nausea, sweating, etc., points towards NMS.
Prodrome, got it.
Fourth, when did it happen? During exercise. While lying down. Those are potential red flags for cardiac causes. Any palpitations or chest pain. Also, red flags.
Exercise or lying down danger signs.
Yeah. Fifth, was recovery spontaneous and complete? Rules out things like postictal confusion after a seizure.
Spontaneous recovery.
Sixth, was there a loss of postural tone? Did they go floppy, suggesting syncope, or did they stiffen or jerk, which might suggest a seizure?
Floppy versus stiff. Good distinction.
Seventh, were there situational triggers? Coughing, peeing, standing up, emotional stress, points to NMS.
Triggers, yep.
Eighth, any recent medication changes? Super important for drug-induced orthostatic issues.
Meds check, always.
And ninth, is there a family history of sudden unexplained death? A big red flag for inherited heart conditions.
That's a comprehensive list. Gold dust for history taking. What about the physical exam? Anything specific the notes mention?
Yeah, the exam adds pieces to the puzzle. The notes highlight checking for orthostatic hypotension, doing lying and standing blood pressures, looking for that drop of more than 20 systolic or 10 diastolic within 3 minutes.
The orthostatic check.
Finding signs of severe structural heart disease on examination, like significant murmurs, and checking for differences in blood pressure or pulses between the arms, which might hint at cerebrovascular causes, particularly subclavian steel.
Okay. History and exam give us a lot, but people lose consciousness for other reasons too. What else could it be? The differential diagnosis section.
Right, so if someone collapses, it's not automatically syncope. The notes group, the main possibility is causing transient loss of consciousness.
What are the big categories?
You've got cardiac causes, the arrhythmias and structural issues we discussed. Neurologic seizures are a major one here, but also TIAs, metabolic thing, hypoglycaemia, low blood sugar, and then a nonspecific bucket, which includes things like vasovagal and orthostatic hypotension, which are types of syncope but sometimes listed separately here.
So heart, brain, sugar, or the fainting types themselves. Do the notes list other specific things to consider?
Yes, they provide more detailed list of other possible causes, which is useful. It includes simple falls or trauma did they hit their head causing the blackout, rather than fainting causing the fall.
Good point.
Epilepsy, obviously. Narcolepsy with cataplexy. Drop attacks, sudden leg weakness without loss of consciousness, but can be confusing. Dizziness or vertigo without loss of consciousness. Sometimes patients describe these poorly. Alcohol or drug misuse, TIAs or strokes. And psychogenic pseudosyncope pops up again, reinforcing how important it is to keep in mind.
That's a wide range. Really shows why that careful history is needed to narrow it down. Okay, so after history and exam, how do we actually figure out the cause? Investigations.
The workup, as laid out in the notes, starts exactly where we just finished. History and physical exam. They're foundational.
Back to basics first.
Always. Then the notes list the standard initial tests. Orthostatic blood pressure measurements, a 12-lead ECG vital for spotting rhythm issues or heart strain, a full blood count, FBC, to check for anemia, and fasting blood glucose to rule out hypoglycaemia, your basic screen.
And if they're all clear, but you're still worried or unsure?
Then the notes say you move to additional tests, tailored to what you suspect. Things like carotid sinus massage, if you suspect carotid sinus hypersensitivity, tilt table testing for suspected NMS or orthostatic problems, an echocardiogram to look at heart structure and function, and cardiac monitoring, maybe a 24-hour Holter monitor or longer event recorder to catch intermittent arrhythmias.
So tailoring the tests based on the clues. The notes mention risk stratification too.
Yes, figuring out how high risk this patient is. The notes mention using syncope risk scores they name Ogiesel and the San Francisco Syncope Rule as examples to help identify patients who might need admission or more urgent workup. It's not about memorizing the scores, but knowing these tools exist to help decide if it's likely benign or potentially serious.
A way to sort the worried well from the truly worrying. What about complex cases that need more?
For those, the notes list secondary care investigations. This might include longer-term ambulatory cardiac monitoring, like an implantable loop recorder that stays in for months or years, maybe ATP testing during electrophysiology studies, more detailed echo imaging, exercise testing if syncope happens with exertion, repeat tilt testing, and the notes make a point. If the cause is still unclear after the initial workup, you need to repeat the evaluation, possibly adding neurological tests.
It's a step-by-step process. And there was a point about older people falling.
Yes, a really practical point from the notes. If an older person has an unwitnessed fall and you can't find another clear reason, you should consider syncope as a possible cause and investigate accordingly. Don't just assume it was a simple trip. Tailor the workup.
Good clinical pearl. Okay, we've gone through defining it. Causes, risks, features, differentials, investigations. Now, the bottom line, what do we do about it? Management.
Management, as the notes emphasize, totally depends on the underlying cause. That's why the diagnosis part is so key.
Right. So, starting with the common one, neurally mediated syncope, NMS.
For NMS, which is often benign, the notes say management starts with explanation, reassurance, and education. Avoiding known triggers is crucial, like advising patients to avoid prolonged standing, sought crowded places, dehydration.
Simple lifestyle stuff first. What if they feel an episode coming on?
The notes recommend counterpressure maneuvers. Lying down with legs elevated is best if possible. If not, squatting down can work. Also, isometric maneuvers, things like crossing legs and tensing muscles, gripping hands and tensing arms. These can physically raise blood pressure for a bit.
Trying to fight it off. What if NMS keeps happening or causes falls?
If it's frequent or causing injuries, the notes suggest a few options, but with caveats. Tilt training might help some people get used to standing. Reinforcing those counterpressure maneuvers. Medications like fludrocortisone or midodrine are sometimes tried, but the notes explicitly state evidence is limited. Same for cardiac pacing mentioned for very specific subtypes, but again, limited evidence and not a go-to.
Limited evidence for meds and pacing in NMS. Key takeaway. What about orthostatic hypotension?
For orthostatic hypotension, step 1 is reviewing medications. Can you stop or reduce any culprits? Then lifestyle. Boost fluid and salt intake, elevate the head of the bed at night. Compression stockings or abdominal binders can help reduce blood pooling in the legs. Those isometric exercises help here too. Medications like fludrocortisone or midodrine can be used. Again, notes mention caution and limited evidence.
Fluids, compression, review meds, maybe try specific drugs.
Okay.
And for cardiac syncope.
Cardiac causes need direct treatment of the heart problem. The notes list things like antiarrhythmic drugs for rhythm issues, pacemakers for slow heart rates, ICDs, implantable defibrillators for dangerous fast rhythms, or even surgery or procedures to fix structural problems like valve disease. Sometimes electrophysiology studies and ablation are needed.
Fix the heart problem. Makes sense. Now, there's a very practical point in the notes about driving here in the UK.
Yes, really important for patients. The notes are clear. For a single, simple vasovagal faint, the common faint with clear triggers, there are generally no driving restrictions, and you don't need to notify the DVLA.
Okay, one simple faint, usually okay. What about recurrent episodes?
That's different. For recurrent syncope, the notes say driving restrictions do apply unless specific criteria are met. And here's that fantastic memory hook from the notes.
Yeah.
The 3Ps.
The 3Ps.
Yeah, to assess if driving might be permissible despite recurrent syncope, you ask. Is it clearly provoked by specific triggers? Does the person get reliable prodromal warning symptoms? And does it only happen in a specific posture, like standing up, not while sitting or lying, which is higher risk? If you can tick all three, provoked, prodromal, posture-dependent, the restrictions might be less severe. Unpredictable syncope, especially supine syncope, means stricter rules. Complicated cases or uncertain diagnoses need careful assessment and likely restrictions.
Provocation, prodrome, posture, the 3Ps for driving. Excellent mnemonic.
It really helps summarize those DVLA criteria. So overall, management is find the cause, treat it, use lifestyle changes, adjust meds, and refer complex cases to specialists.
Great summary. Finally, looking ahead. Prognosis and complications. What's the outlook according to these notes?
The notes state clearly, prognosis depends entirely on the underlying cause. For many, especially with NMS, the outlook is good, it's benign.
That's reassuring for many patients, but complications can happen.
Oh, absolutely. The main one highlighted in the notes is injury from the fall during the syncope, bruises, cuts, fractures, head injuries, even road accidents if it happens while driving.
The fall itself is a major risk.
Definitely. And the notes also mention that recurrent syncope, even if the cause isn't life-threatening, can severely impact quality of life. People become anxious, afraid to go out. Morbidity is high, especially in the elderly, often due to those fall injuries. Poorer outcomes are linked to the severity of any underlying disease, especially heart disease.
So injuries and quality of life are big factors, and there was a specific point about mortality risk.
Yes, this is crucial. The notes point out specific risk factors associated with increased mortality, even in patients initially thought to have non-cardiac syncope. These are an abnormal ECG, being over 45 years old, and having a past history of ventricular arrhythmias.
Hold on, so even if you think it's just a vasovagal faint, if the patient also has an abnormal ECG, is over 45, or has that arrhythmia history, their overall risk is higher.
That's exactly what the notes imply. It suggests these might be markers of underlying cardiovascular fragility, increasing overall mortality risk, whatever the immediate syncope triggers seem to be. It's a really important point for risk assessment. Don't get falsely reassured just by a simple faint diagnosis if these other red flags are present.
Wow. Abnormal ECG, age over 45, history of VT red flags demanding attention even in seemingly simple cases. That's a critical insight.
That's all.
This deep dive has pulled out so much key information. So here's something to think about. Given how incredibly common syncope is, especially as people get older, and this huge range from a simple faint to a sign of serious heart trouble, how could a better, more widespread understanding of these distinctions actually change how healthcare systems manage these patients? Making sure the high-risk folks get the urgent workup they need, while maybe avoiding over-testing everyone with a simple faint.
That's a great question. It really comes back to that initial assessment, doesn't it? Nailing the history, using those risk stratification tools effectively, maybe having clear pathways. It could potentially save resources and target investigations much better, improving safety for the high-risk group without subjecting the low-risk group to unnecessary procedures.
Yeah, efficient pathways based on good initial assessment. Well, we've covered definition, mimics, the why, risks, features, differentials, investigations, management, including the 3Ps, and prognosis and complications. A pretty thorough look at these notes.
Definitely.